At Cairo University's Qasr Al Aini Hospital, decades of clinical history intersect with modern medical research. Here, the Thoracic Surgery Unit, led by Professor Dr. Tariq Mohsen, evaluates some of the most complex congenital chest wall deformities seen today. For over half a century, the medical consensus for treating these anomalies was clear-cut: correct the structure with an invasive open operation. Today, clinical evidence supports a far less invasive approach. Dynamic compression bracing is the globally preferred first-line treatment for qualifying patients. Successful outcomes now depend on the surgeon's ability to distinguish between a candidate for remodeling and a candidate for reconstruction. Pectus carinatum is an outward chest wall deformity. Unlike pectus excavatum, which sinks inward, carinatum pushes the sternum forward, driven by an overgrowth of costal cartilages. This overgrowth typically presents in the lower sternum, the chondrogladialar type, but can also appear higher up near the manubrium. This condition rarely presents in early childhood. The outward expansion accelerates rapidly during early adolescence, precisely when the body hits major growth spurts. Beyond the physical contour of the chest, adolescents experience severe psychological distress. A sudden loss of self-confidence and withdrawal from social interactions are the primary clinical drivers for medical intervention. The initial clinic visit determines the patient's entire treatment trajectory. To proceed with conservative bracing, a patient must meet specific criteria: a mild to moderate deformity, the capacity for high daily motivation, and a highly flexible chest wall. This chart plots flexibility across a lifespan. The data highlights a biological window between ages 10 and 16, where cartilage is most pliable. As late puberty hits, the window closes. The cartilage solidifies, causing the chest to lose malleability. Identifying a pliable chest during this active growth phase is the absolute prerequisite for entering the bracing pathway. The biological principle behind dynamic compression is identical to orthodontic braces. By applying constant external pressure against growing cartilage, the tissue remodels at a cellular level. Over months of sustained tension, the chest wall literally rebuilds into a flatter contour. Achieving this correction requires immense discipline. During the intensive correction phase, the patient must wear the brace for 14 to 23 hours every single day. Once the sternum reaches its optimal position, the patient transitions to a maintenance phase. The daily hours are reduced, but the brace must still be worn consistently for anywhere from 6 months to 2 years. Dynamic bracing is a grueling biomechanical marathon. It demands physical endurance from the patient as much as it relies on the biology of a growing body. Because of these strict biological requirements, certain clinical scenarios guarantee that a brace will not work. Severe structural rigidity, complex asymmetrical curves, and the calcified cartilage of adults resist external pressure. Applying a brace in these conditions only leads to frustration. For these specific outliers, the clinical assessment points directly to modern surgical reconstruction. Surgeons utilize established operative interventions, like the modified Ravitch or Abramson procedures, to manually reshape and secure the rigid chest wall from the inside. Opting for an operation is the application of the correct scientific tool for a biologically rigid environment. Even when the diagnosis is accurate and the chest is flexible, one unpredictable variable dictates the final outcome. This chart measures treatment success rates against daily brace usage. Strict adherence is the strongest predictor of success, but adolescents face psychological friction. Physical discomfort and social stigma lead to skipped hours, stalling remodeling entirely. A robust family support system is required to keep a teenager motivated through the long, often frustrating months of the protocol. The most advanced biomechanical pressure system is entirely useless if the patient lacks the willpower to keep it on their body. Returning to the clinics of Cairo University, Professor Mohsen's core philosophy centers entirely on this human element. The team operates on a strict mandate. They do not treat CT scans or anatomical images. They treat the entire patient, evaluating physical flexibility right alongside psychological readiness. Internet research can list statistics, but evaluating a patient's capacity to endure treatment requires the nuanced judgment of an expert thoracic surgeon. When the assessment is accurate and the patient commits, the outcomes extend far beyond a flattened chest. Anxiety drops, body image improves, and patients return to their normal social lives. Evidence-based medicine is the practice of matching the correct physical tool to the right patient at the exact right moment in their life.